let's go ahead and get started. So first off, welcome everyone to our November didactic lecture with Dr. Amy Clement. Just a brief introduction on Dr. Clement. She practices obstetrics and gynecology at Memorial Medical Center in Las Cruces, where she specializes in comprehensive sexual and reproductive health care, preconception counseling and prenatal care, complex contraception management, adolescent gynecologic care, and high-risk pregnancy management. She earned her medical degree at the University of New Mexico School of Medicine in Albuquerque, New Mexico, and served her OBGYN residency at McGaw Medical Center of Northwestern University in Chicago, Illinois. With that said, Dr. Clement, the floor is yours.
Great. Thank you so much, Mario. Thank you, everybody, for joining me today on your lunch break. I'm really excited to talk about this topic. It's something that I think is a really, really important subject.
There's two. There's the article and then that.
And can we just have everybody make sure they're muted? Thank you, sorry. Perfect. So very excited to talk with you about this topic today. It's something that I think is a really, really important part of primary care. And I think that, in the last 6 months, there's been a tremendous amount of attention on the discussion around abortion and abortion access. But I think that it's really important to just take it back to basics and not just think about abortion rights, but think about pregnancy options counseling more globally and what you as a primary care provider can do for the patient in front of you. In addition to my residency in Chicago, I also completed a 2-year fellowship in complex family planning at the University of Utah, which is the subspecialty of OBGYN that manages abortion and contraception care. Okay, so I have no particular financial disclosures for this talk. The opinions I'm presenting here are my own, don't represent my institution or employer. In terms of our objective today, again, I really want to keep this basic and focused on counseling. So the first thing we're going to go through is how to share the results of a pregnancy test as neutrally as possible. Next, we'll go through some very specific strategies to talk with patients about options for pregnancy. And then I would like to frame this whole discussion sort of within a reproductive justice framework, because I think the principles of reproductive justice can be really, really helpful guiding good comprehensive counseling. Okay, so let's start with an example patient here. Let's say that you're in clinic. On your schedule, you have Carla. She's 32 years old. She's had several pregnancies before, and she's coming in with a chief complaint of missed period. She's otherwise a healthy lady with no significant medical or surgical history. And in the past, she's had a delivery, she's had a miscarriage, and she's had an abortion. So what are your next steps with this patient? And somebody can unmute and shout it out or pop it in the chat. What do you want to do first? Great. Thank you, Christopher, for being brave. So everybody's thinking it. Start with pregnancy test. And you might think that a pregnancy test is, and I have a very good point, last LMP, very helpful information. So you might think that pregnancy test, very simple thing, but there is a strategy for delivering the results of a positive pregnancy test, particularly in the setting of an unexpected pregnancy. And I think it's really important to recognize that for some people, that positive pregnancy test might be what they've been hoping for, wishing for years. And for other people, it might not be such good news. And we don't want to make any assumptions when we're seeing somebody. Now, a lot of times in my clinic, the medical assistant has already run the pregnancy test before I ever see the patient. But if you're in the situation where you happen to have a chance to talk to the patient before the test, it can be helpful to kind of get a sense of what they're feeling or thinking even before you run the test, because that can kind of help start and guide your conversation. So throughout this talk, I've given some, or I have some examples of different statements or phrases that you can use. Obviously, every person's style is different, and this language, some of the language might feel awkward to you, but they're just suggestions to kind of help guide your counseling. So you might ask the patient, what do you think the result will be? What are you hoping it will be? And then when you're asking that, making sure that they're not feeling stigmatized or anything with how they answer it, but kind of also adding, no matter what, we'll take care of it. We'll help you figure out a plan. Okay. So say that you didn't have a chance to talk to Carla beforehand. Your MA is just like, she's in room 3, her pregnancy test was positive, I haven't told her yet. So when you're going into the room and you're sharing this result, you want to just try to be as neutral as you can, but also very clear. So a statement like, your pregnancy test is positive, which confirms you are pregnant. Neutral. No, not congratulations, nothing like that. Just a statement to share that information is a really good place to start. And then recognizing that that's our launching off point potentially for a counseling session about options, and recognizing that everybody has many options when addressing an unintended pregnancy. So again, we're starting very neutral, not making any assumptions here. And before we dive into some just specific strategies for that next step of the conversation, I want to just review a few basic counseling principles. So again, we've kind of already mentioned some of these, but you want to, again, we are being as neutral as possible, listening without any agenda, do not make any assumptions about what somebody might want to do or plan to do with the pregnancy. And you want to make the space as safe as possible for the patient to share or disclose their plans, their worries, their fears, anything like that. And then regardless of how you personally would act or feel about each pregnancy option, we as healthcare providers in this space have an obligation to provide our patients with accurate information and also refer for appropriate services as needed. So again, you don't personally it might not be something personally you would choose for yourself. But again, in our role as healthcare providers, just again, providing neutral, accurate information is really important here. And I mentioned how I think it's really helpful to frame this counseling within a reproductive justice framework. And many of you may be familiar with some principles of reproductive justice, but I just want to review some basic points in case you're less familiar. But basically, the reproductive justice movement framework was developed by women of color in Chicago, I think almost 3 decades ago now. And specifically, many of the women were founders of this organization, Sister Song. And basically, the idea with reproductive justice is that we have a right to personal bodily autonomy, which means not just a right to an abortion, but a right to have children, to not have children, to parent in a safe and supportive community throughout our lifespan. And so it's really that idea of like full reproductive personal autonomy. And within that, recognizing that there's a lot of historical power imbalances and sort of systems that are intentionally or unintentionally oppressive to some segments of our population. And so when we're considering this framework, really centering folks that have been historically marginalized to ensure that we're being very intentional and ensuring good access for everybody. And again, it's about access, not just choice. So having abortion be legal in New Mexico doesn't necessarily mean it's accessible to everybody, and doesn't necessarily mean everybody can make it to Albuquerque for a second trimester procedure in terms of travel, time off work, childcare, kind of considering that larger access issue. And then again, This is not just about abortion access. This is about access to all reproductive health services that help somebody achieve that kind of complete bodily autonomy. So again, I think kind of thinking in this framework as we're going through this counseling can be really helpful and can make for a more productive conversation with everybody. Okay, so back to Carla in room 3 with the positive pregnancy test. So we just kind of told her this. We said, hey, Carla, we have the results of the pregnancy test and it was positive, which confirms you're pregnant. First thing we want to do is check in with her emotionally and kind of acknowledge any feelings. So starting again with a really neutral statement, open-ended, then be quiet and just allow some silence, allow her some space to tell you how she's feeling. And then any feelings she's having, positive, negative, neutral, any of them are totally normal and totally okay. And it's really important for us to explicitly validate any emotions that somebody is having. And again, this is about making that safe, not stigmatized space. Okay. Here's some other examples of validating and normalizing statements that can kind of be used throughout your discussion whenever somebody really does express some feelings or strong emotions about something. I think really acknowledging that, naming it, is a really important piece of counseling, and not just purely providing information and options, but really acknowledging the potential emotion that comes along with it. And if somebody doesn't have strong feelings, that's also okay too. These are 2 of my favorite statements that I use a lot in this counseling. Is it's okay not to know how to feel, know the answer, know what to do. And then also really normalizing any question that somebody would ask. That's not a strange question at all. I'm really glad you asked. But again, some of these statements might feel more natural to your speaking style or your counseling style than others. And these are just kind of suggestions to use as a jumping off point. Okay, so we kind of shared the news with Carla. She told us a little bit about how she was feeling. And now the next step is to kind of get a sense of what she's done before with pregnancy. She's had several pregnancies, so she's probably, thought about this before, although each pregnancy is different. And if she's aware of what potential options she does have in pregnancy. And again, even if somebody's had babies before, it's important to not assume anything here, but kind of starting with some open-ended questions about their pregnancy experiences, or if they've ever thought through what they would do in this scenario, can be helpful. And if somebody really doesn't know a lot about pregnancy, has never been pregnant before, really doesn't volunteer any options to you, you can also just ask them a very general statement. Are you aware of what your options are regarding the pregnancy? And then if you need to they might volunteer 1 or 2 options. I always kind of take them through all the options, just to make sure that, again, we're not making any assumptions about their knowledge. So after kind of assessing where they're at with this, then I do kind of a general statement about the pregnancy options. And just for everybody's review, there are 3 options with pregnancy. The first option is to continue the pregnancy and deliver, and then become a parent afterwards. The second is to continue the pregnancy and make a plan for adoption after delivery. And then the third is to choose abortion or end the pregnancy. And this language, the statement here is kind of, again, a very neutral, general way to address this. Sometimes in clinic, how I do it is I say, it seems like this was kind of a surprise. How are you feeling about this? And then you say, I always like to ask everybody just about what they were thinking about doing with the pregnancy. With every pregnancy, we always have our 3 options. go through it then? And then had you had any thoughts about that? So that's kind of the language that I use. And again, you can kind of modify as you like here. I don't typically at this stage go into medication or surgical abortion unless the patient specifically asks and is like already decided on abortion. I just kind of generally present that as a single option. And then if they have have questions, we can go into details and stuff down the line as they like. I think what's really important to know is that most people will have a really high degree of very quick decisional certainty about this. A lot of people will just know what they are going to do. And potentially that's because they were already suspecting and had already been thinking about that, or they just kind of like know right away what they would do. So sometimes your counseling kind of doesn't have to continue too much beyond this. If they're very confident and they kind of can state to you what they were planning to do, then at this point you can kind of just transition into referral resources to help set them up with whatever option they'd like. But for your folks who are having a little bit of kind of like still shock, uncertainty, that sort of thing. So sorry, a quick aside. We'll get to that in a sec. A quick aside about language here. Language is really important throughout counseling about sensitive issues, as we all know. And we're always going to make language missteps. None of us are perfect, but some suggestions for very neutral, non-judgmental language in this space when we're talking about options is, instead of saying something colloquially like keep the baby, which we hear a lot, just kind of again in general conversation, using a more neutral term like become a parent can be helpful. Instead of saying give the baby up for adoption, making a plan for adoption. And then instead of saying terminate the pregnancy, say have an abortion. And this one I think is a little bit tricky. I'm personally guilty of using terminate all the time. But I do think it's important to use the word abortion. Don't whisper it. Don't, it is healthcare. It is a valid choice. We want to destigmatize everything as much as possible. And so don't be afraid to use the word abortion. Okay, so back to your undecided patient. You've presented these options and she's just really overwhelmed and not sure. A next really helpful potential step is to figure out if there's anybody they can kind of talk with about this and kind of talk through this decision. And one potential place to start is sort of getting a sense of their relationship with the person they got pregnant with. And if they're still in touch with this person, if it's a safe relationship, if it's a relationship where they feel comfortable just talking about this, have they already talked about this as a possibility? So that person potentially can be a very constructive, helpful person. On the other hand, sometimes that's not always the best support person. And so asking a more neutral question, is there anyone in your life you can talk with about the pregnancy, can be helpful. For your younger folks, I do think it's really important to kind of check in with them about their relationship with a parent or guardian, see if this is something they'd be comfortable talking through with a parent, because basically with any pregnancy option at some point, the parent or guardian is probably going to know and probably going to get involved. And so I just kind of getting a sense of what that relationship is and if that's a supportive relationship or if that might be a barrier to any one of your options. And then this is another just neutral question that you can try here. And I think that, these questions can also kind of help you get a sense of the patient's larger kind of social context. Again, when we're thinking not just about choice, but about access, sort of the reality of what it would be like for them to pursue each of these options. And this can just be like a nice segue into just learning more about your patient's life and situation. Another strategy that can be helpful at this stage is encouraging the patient to think about making a list of sort of what would be good and what would be hard about each of the pregnancy options. and potentially going through this list with a trusted support person can be helpful. Some people find the list making artificial and not helpful. Some people find it very helpful to organize their thoughts that way. So I don't necessarily recommend routinely doing it for everybody, but it can be a tool if somebody's really, really undecided and really is somebody who likes kind of laying everything out systematically. Okay. So a lot of times by this point in the conversation, somebody's going to have a pretty good idea of where they're headed, what they're thinking. But again, if your patient is still very, very unsure and really needs time to think about this, to talk with their support person, the kind of last final piece of your counseling is really letting them know what a timetable for a decision is. And I think that, reassuring them that it's totally normal not to know what to do. It's that we absolutely want them to take as much time as they need to make any decision. But if one of the options they're considering is abortion, then just giving them some basic information about timeline that they would be looking at if they were interested in this option. And this might be review for a lot of you, but again, we have the options of medication for abortion or surgical procedure. Medication abortion can be used up to 11 weeks. And in this state, we're fortunate that we have both telehealth and in-person options available. Surgical abortion can be for anybody less than 11 weeks that just prefers a surgery procedure, or up through the second trimester, and in rare cases, a little bit into the third trimester. I pulled the current gestational age limits that are listed for, I think, 4 clinics that I'm aware of in the state that are offering second trimester procedures right now. But I, of course, advise the patient that these are they're approximate, and they should call, if they're thinking about this, they should call the clinic to confirm availability for their situation. If the patient just needs more resources to kind of talk through making a decision, these are 3 very helpful decision aids that are all very neutral. So they're not going to push somebody towards abortion. They're not going to push them towards parenting. They're very neutral resources. So one is an online workbook that can kind of help somebody, again, particularly for that list maker person who really wants to think through pros and cons. This all options resource is both a website and a talk line. And then for your patients that express a lot of spiritual conflict with this, which I think is very common, and particularly where I am in the southern part of the state is very common here. This Faith Aloud resource is specifically designed to help people kind of navigate spiritual or religious questions around, particularly around abortion. So I think that this can be a really, again, it's a very neutral counseling resource, but can really be helpful for navigating kind of those questions and that nuance. Great. Okay. So we kind of talked through our patient, kind of laid out everything for the patient now. And your final step is helping provide referral resources based on whichever option or options they are considering. So if they're considering continuing the pregnancy, then the rest of your visit, you want to make sure you're reviewing their medications to make sure everything's safe, encourage a prenatal vitamin, talk about substance cessation. And then if you're not a prenatal care provider, then getting them hooked in already with a referral for somebody who provides prenatal care in your area. And I think this is important, even if somebody's also considering abortion, that, counseling them to consider doing these things as well, because they're not sure which way they'll go. And we do want to start off with a healthy pregnancy, if they are potentially going to continue. And I think it's important to tell people, hey, if you decide to pick an abortion, that's fine. You can cancel this appointment. You don't need to kind of go follow up with the prenatal provider. But just in case, I want to get it all set up for you now. So in terms of referral, if somebody's considering making a plan for adoption, I will say this is probably the hardest option of all three for a variety of reasons. I have recently relocated to the state, and I am not as familiar with very local adoption resources here yet. But these are two national adoption resources that work with patients in all states, and again, are extremely neutral. So they're not going to, stigmatize anybody who's previously considered abortion, that sort of thing. They're going to be very neutral in supporting folks. And so I think these are good resources to start with. And if anybody has a really good, central or southern New Mexico resource that they are aware of, feel free to pop it in the chat. But again, I think there's there are a lot of adoption agencies out there, but these are two that are, again, going to be a very kind of neutral approach to counseling with your patient. Okay, and then finally, if somebody is thinking about an abortion, again, we're very fortunate in the state that we have very good access. We don't have particular restrictions on care, but we do want to kind of talk about, again, the timeline for decision-making, particularly between medication and surgical options. And we do recommend that as soon as somebody is sure and decided, that they try to get that scheduled as soon as possible, because the procedure is easier and cheaper if they are able to get it sooner. And also because I know that our state is having a lot of folks traveling from other states for care right now. And so the wait times might be a bit longer. So important to just get on the schedule as soon as somebody's even thinking about it. And they can always, of course, change their mind at any point prior. There is potential insurance coverage for this procedure in this state. That's pretty unusual in this state. It's not true everywhere in the country. And there is Medicaid coverage, although the patient, of course, should check with each individual clinic to clarify, what the cost might be. And then just make sure the patient's aware that they should ask about financial assistance if cost is a barrier, because there are many, many abortion funds that can help a patient out as they need, and can also help with logistics like travel and, not necessarily childcare, but kind of helping set up some of those surrounding facilitators to help them get to an appointment. This website, I think, is the current best source of abortion providers, both telehealth and in-person, that exists in this country right now. They keep it quite up to date. And basically, the patient just puts in their address or their zip code and their last menstrual period. If they don't know, that's fine, but the last menstrual period is just to guide them towards resources at the appropriate gestational age. So this is what I've been using recently in the last few months, and I think it's a very good resource. So, perfect. Okay. So we've kind of talked about the basic principles, and let me actually pause here and see if there's any questions, and then we'll talk through some kind of harder scenarios and questions here. So I'm not seeing any questions right now. If anybody has anything, feel free to pop it in the chat or unmute yourself, and I'll just give it a minute or two here, and then we'll dive into some harder topics.
Hey, Dr. Clement, this is Dolores Gomez. I know that you're just here now, but can you give just a little bit of background? I know we have a couple of places here in town. I only know the name of one off the top of my head, Turning Point, which talks a lot about you can come see us and, we'll help verify your pregnancy and give you options. Do you have any thoughts or information on that at this point?
So I think that you might be alluding to the idea of a crisis pregnancy center. Yeah. So I think that what's really important, and one really useful thing we can do as providers of accurate information, is guide patients towards clinics that actually would offer abortion and aren't just crisis pregnancy centers, because most crisis pregnancy centers will counsel folks against abortion and will counsel them towards pregnancy continuation. And so I think that they're not necessarily giving a patient an unbiased thing. And I'm not familiar with any of the specific ones in town, but patients should be anything that's like a pregnancy resource center. You can let them know they're welcome to have a discussion with them, but just let them know that those places don't always offer referrals for abortion care. And so I typically recommend, if somebody's considering an abortion, that they even potentially schedule or make an appointment with the clinic that offers it. And they can always change their mind once they've had a visit with the counselors and everything like that. But actually, they should look carefully on the website if it offers it. And again, be cautious of anything that says, a pregnancy resource center, that sort of thing. Those websites that I list, or the all options and the kind of workbook thing, are very neutral tools that I would kind of direct people to first. But it is problematic with the pregnancy resource centers because they really popped up a lot. And I think that patients it looks helpful, but they don't always realize they're not necessarily getting the full scope of options counseling when they go there. So, but for your patient that's maybe definitely going to continue, but maybe thinking about adoption, those centers I think are better connected with some of the adoption resources in town. So if abortion is something that's not even on the table for them, then potentially a facility like that, they might find that helpful for that individual. So good question. What else do we got in our chat here?
Yeah. Hey, Dr. Clement, this is Clark. Can you hear me okay?
Yep.
Yeah, it looks like there's some questions in the chat, but one question I had, how important is it to get a first trimester ultrasound to confirm dating based on LMP when you're trying to decide which abortion service to offer?
I think it is extremely helpful if you're able to, because it can also expedite a referral if a clinic really knows exactly how far along somebody is. And particularly if somebody has a younger person has really no idea of their period, I think can be very helpful. Not required, and sometimes I have patients simultaneously start calling around to see if they're interested in abortion, and then also simultaneously order an ultrasound. And if the clinic's able to get them in without an ultrasound beforehand, great. But otherwise, if they're kind of delayed, then we can get the ultrasound in the meantime. And if you have the ability to do a brief dating ultrasound in your clinic, great too. But it's not so much that I worry about missing ectopic pregnancies or that sort of thing in this situation. It's just more because I know some clinics are scheduling out, and just to have the patient with the best dating possible, I think can help facilitate easier referral.
Great, thank you.
So let's see here. Should the patient be necessarily from New Mexico to get those services? So patients do not have to be from New Mexico to access abortion services here. I think one big barrier for folks traveling from out of state is frequently cost, because insurance coverage is actually quite unusual for abortion. It's not like when I was in Utah, nobody had coverage for abortion. So it was all basically cash. And so I feel like the cost barrier and then travel barrier and that sort of thing. But certainly, aside from the insurance side and the travel side, there's no prohibition on somebody from Texas getting care here in the state. And options for people in New Mexico without insurance seeking abortion services. Yes. So there are a number of abortion funds. Most of the clinics have links to them on their websites. The clinics can also direct. People can also look up just like New Mexico Abortion Fund and just Google it, and they will get connected to those resources. But going through the clinic is often best, because the clinics sometimes have relationships with particular funding deliberately set aside. And, there's a lot of really great organizations, again, kind of working from this reproductive justice standpoint, to take away cost as a barrier, to take away travel as a barrier to folks getting this care. And a lot of it, I will say, is emphasizing on people who are having to travel across state lines right now. But I know there are definitely resources for folks in the state as well. Great questions. Okay, let's go through some hard questions and then we can circle back to everything else at the end. So these are the questions that sometimes will make you squirm, will make you sweat, that you're afraid of getting in this conversation. And I will say these are not the perfect answers to these questions. They're just some suggestions about how to approach this. And I have gotten all of these questions many times. So, number one, am I a bad person for considering abortion? So this one, typically when I'm kind of thinking about hard questions, again, you really want to acknowledge any emotion in it, then try to kind of understand where they're coming from, what makes them say that, and reframe. This one's I handle a little bit differently, and I kind of a little bit more just directly answer and then step back to that. So I think it's really important to just refute that right off the bat. Because that can be like a really harmful, negative thought pattern for somebody to get in. So this is one statement. This is the one that I stole from the UCSF counselor on this. I think this is just make it very clear that you are not a bad person and will support you any way that whichever decision you decide to make. And then I might follow that up with, I know that can be a really hard question to ask. So, thank you so much for asking it. Thank you so much for bringing it up. Can you tell me more about what you're feeling? Can you tell me maybe a little bit more about what you've heard about abortion? And then see if there's anything in there that you can they have some misinformation about the procedure, about anything, and see if you can kind of drill down where that feeling is coming from. But I think this is so important, particularly when we have so much kind of really hateful rhetoric around reproductive health care, that we are kind of nipping this one in the bud. Okay, so that's the first hard one. Next hard one. I am worried that God will punish me, or some other sort of variation on this that's about spiritual conflict, going to hell, not being forgiven, that sort of thing. This one for me is the hardest, because I'll just share personally that I don't attend any particular church, and I consider myself to be spiritual, but not particularly religious. So I don't have a lot of background in understanding religious theology and philosophy. So I find it a little harder to navigate these ones. But here are some very basic kind of neutral statements to start with. That again is really kind of acknowledging that feeling and then trying to get some more understanding about what is making them feel that way or what they've heard or that sort of thing. And then sometimes you can kind of shift this towards a conversation about forgiveness. And many people will find, that they will acknowledge that God is very forgiving and that, so you can typically open up a nice conversation again by just really acknowledging that emotion and then just very curiously trying to explore their beliefs. If you are still really stuck in and you feel like you haven't adequately answered the spiritual conflict, that Faith Aloud resource that I mentioned earlier is immensely helpful. And that's actually spiritual leaders, including pastors and rabbis, that kind of work with that helpline to help really people talk through these questions very specifically, because it does come up a lot. But that one for me is probably the hardest one personally for me to take people through. And then the last hard question I want to bring up is, what do you think I should do, doctor? And this one is also can be really tricky, that somebody is feeling overwhelmed and they just want to put the decision, they want to put the decision on you. And I think that, again, validating that's a totally normal feeling and response. And then I think just saying something along the lines of, that it's a really personal decision. I'd have to think through it for myself, all these things that you don't have to disclose anything about what you believe or anything like that, but sort of reframing it back about what an individual personal decision it is, and each pregnancy is different, and sort of kind of reframing that back to the patient, to really illustrate to them that it's their decision. And again, and it's okay if somebody's not ready to make a decision. And I think, like, if they're just thinking that you want them to make a choice, then being like, oh no, we actually don't need to make a decision on this today. Like, we can circle back to this. So that's kind of how I address that one. So to summarize here, we're exploring feelings after giving a result. We're giving that result as neutrally as possible. Then we're kind of seeing where the patient's at with knowledge and experiences. If they aren't super sure about what they want to do or aren't really aware of options, then presenting those neutrally with good non-judgmental language. For your folks that are still undecided, identifying social supports can help them to make a decision. And then if somebody is undecided, making sure that they're aware of timetables if they were considering an abortion. And then, of course, referring or providing services as appropriate. And then just making some kind of a plan for a follow-up or check-in, particularly for folks with ambivalence. It could just be, hey, can I give you a phone call in a week to check in and see how you're doing, see if you need any help getting any appointments set up, something like that. It doesn't necessarily need to be coming back for another visit unless that's the patient's preference. But just making sure, again, that leave that door open for further conversation. Okay. Great. Okay, so we still have about 10, 15 minutes left. I'm happy to take any other questions that folks have. Okay, let's see here. Have you had any experiences where maybe the mother and the partner don't agree on what to do with the baby? Yes. So this can also be, I almost left this on as one of the harder scenarios where a partner is maybe coercing or forcing or that sort of thing. It can be really, really tricky. And I think what we just have to remember is that our obligation is to the patient and the person who is pregnant. We aren't necessarily going to fix or solve whatever relationship thing is happening, but kind of, well, so first of all, assessing relationship safety and making sure that there's not a concern about emotional violence or, physical violence or anything like that. And if somebody has an acute safety concern, then hooking them in with your social worker or emergency shelters or that sort of thing. But if it's more just that they don't agree, I think just reinforcing that it's the patient's decision, and that reinforcing that, welcoming the partner to be involved in visits, either prenatal visits if they're continuing, or the abortion counseling visit if they'd like to come. And then, trying to identify other social supports to kind of help the pregnant person navigate that. But it can be very, very tricky. I will say at the end of the day, typically, even if they're not like completely in agreement, in my experience, most partners have been very willing to, go along with whatever the pregnant person decides. But it can be a very tricky thing. And in the abortion care setting, we're always really watchful for if we think somebody's being coerced into a decision to end a pregnancy. So, I should have put that as a hard scenario because that one's really tricky too. And a lot of times it's not like a single visit to solve that, but it might be kind of a little bit of back and forth and again, but just really encouraging the patient, it's their decision, and then assessing safety and trying to identify other social supports. Long rambling answer to your question, but excellent question. What else?
Dr. Clement, it's Dolores Gomez again. Just kind of, if you can speak a little bit personally towards you as a provider, helping patients navigate this. You know, obviously we should always take away the emotional or the, you know, unfortunate political side of these things. But tell me how you as a provider have navigated being able to talk through these services and offering these services, and kind of what ramifications or things that you have seen personally in terms of being a provider that goes through these informed decisions.
Absolutely. Well, I think the most important thing to know is 90+% of the time, this is a very straightforward conversation, and patients really, again, know what they're like almost off the bat. They know what they're going to do. And so a lot of the discussion often trends more towards that, kind of helping them access services and doing a referral and just kind of being aware of whatever services and resources are in your area. So we'll say it's extremely rare, you know, to have somebody who has really high decisional uncertainty and that there's kind of a long conversation with this. But it does happen, absolutely. And so I think not one tip I would say is, like, if the patient's really clear and they like know what they want to do, it's okay if they don't have a lot of emotions about it. It's okay if they don't have a lot of conflict, and you can just keep it simple, and you don't have to like go through all of these things. But not being afraid to dive in to those discussions. The other thing is, you know, within your clinic or your practice, keeping in mind that your staff, your coworkers might feel differently about this. And so what I try to do, again, is just to be as neutral as possible about it with everybody. And just make it clear that I am happy to engage in this discussion. I'm happy to see patients who want to do this. And I think that, again, just making the kind of trying to destigmatize it and making it a safe space. But we don't all have to agree on this, but just making it clear that, you know, you're happy to engage in this conversation, and, you know, and it's okay for it to sometimes be easy and sometimes be difficult. So another long rambling question or answer to your question. It was interesting in Utah. I was mostly in the setting where I was already caring for people who'd already were coming to an abortion visit. And so, and I think that reassuringly to, you know, many people are like, you know, are people really conflicted about this decision? It's very reassuring that, you know, 99% of the patients, by the time they hit the door with their appointment, they have incredibly high decisional certainty. They're extremely confident and comfortable with their decision. And I think that we really, there's a lot of like logos and statements like trust women. I say, yes, just trust the pregnant person in front of you, that they can make this decision and you're just guiding them.
Amy, I was just trying to figure out if I was on mute or not. This is John. I really appreciate this. I had a couple of comments. Number one is, I'd like those of you who feel comfortable and who have the ability to turn on your camera, because it's nicer if we have a conversation face to face. If you're not comfortable or you can't do it, that's totally cool. And the second thing, and I think most important thing, was the whole framing around reproductive justice. And I think that's huge. And I'd like to, I don't know, I'd like to open the conversation around that specifically. I mean, I think the right to bodily autonomy is huge. But I think the second part is to have children or not have children, and raise them in a safe and sustainable community. That is, I think that's a really huge part of what we talk about in family medicine in general, right? And our responsibility to look at those barriers that challenge our patients and reduce some of those barriers as we can, or even just recognize the barriers and help mitigate some of those barriers. And I think lastly, not be a barrier. And sometimes we can be barriers. So I just wanted to throw that out there and see if anyone else had any thoughts around that. tough. Those are hard things, right? So
Yeah, and I think it's sometimes you can feel overwhelmed by this, that we're not going to fix all these issues in this visit, but I think it's just, as you as a clinician, just being aware that they're there, and that this is not just making one of these 1, 2, 3 choices. This is also, how do we then implement this choice? How do we get you connected with safe prenatal care when you live in Lordsburg and you're driving 2 hours every time you need a prenatal visit? And with, you want an abortion, but you live a couple hours from a clinic that can offer it, and you have 3 kids, and just kind of really thinking in this framework, and then recognizing that, again, there's certain populations, particularly folks of color, that have been really marginalized with this historically, and they're particularly vulnerable, and we need to be really, really aware and cautious of that.
I think I think that's so huge. I remember when I was a medical student working in the ER and congratulating this family about this positive pregnancy test. And it was the worst thing I could possibly have done.
We've all done it. We've all done it.
Like, congratulations. And they looked at me very unhappy.
Yeah.
And so, it was a lesson learned a long time ago, but now I think about the structures in which a person lives. I can't afford this. It's going to harm my children. I can't finish my education. I can't, and all the structures that could possibly be in the way that's facing that individual, and how we lessen that. So I don't, so to me, it's something really personal, because I've stepped in it. So I think this is a wonderful conversation to have.
I will put my email in the chat too, if anybody has any questions that they're not super comfortable asking in a group setting, but would like to have a conversation about, either by email or by call later. Mary Alice Scott, you're welcome to oh, you can't get the mic on. If they have any other questions, we'll give it a sec. And if anybody else has any other questions.
I have a question, Dr. Clement.
Yes.
Given our proximity, like how close we are to the US-Mexico border, what's your experience with interacting with patients who, don't speak English as their first language?
Oh, this is a good question. And I think that's another really important potential access barrier to somebody calling up a clinic and making an appointment and navigating that. So I unfortunately am not a bilingual provider, but certainly we have, I think, being really aware of that. And then if you are using an interpreter, making sure that your interpreter is also aware of the importance of being very neutral in their language that they're using. And, having an interpreter and you trust is going to be really giving accurate and reliable information can be tricky. I actually think that I haven't seen a lot of patients coming up from Mexico for abortion. I think it's actually, the traffic is currently more going the other direction, because I think that the access to care is a little bit better there right now, as particularly compared with Texas. But I do think that language barrier is really, really potentially important for a patient navigating things themselves and resources themselves, and also then making sure your interpreter is really using those neutral principles as well. And I think sometimes you do kind of lose that. You're trying to do this whole thing, you're creating the safe space, all these things, and then something gets a little bit lost in translation. So excellent question. Okay, well, I have to run back to clinic, but I really, really appreciate everybody engaging in this. I know it can be a tricky topic, and I really, really, I'm so glad everybody asked really thoughtful questions. So again, please feel free to reach out to me if you want to continue the conversation offline. And thank you, Mario and John, for inviting me again.
Yes. So thank you, Dr. Clement, for being here today. Thank you, everyone, for attending, and just the level of interaction was great. And in the chat, I've placed 2 links. One is to register for our next didactic lecture, and the other is to take our post-lecture survey. So if there are no other questions, thank you very much for being here today.
Thank you, Amy. That was awesome.